Roger, read the chat.
All right, good morning, everyone. Thank you all for joining us. You have made it to the City of Paterson, Ryan White HIV/AIDS Program, Clinical Quality Management Committee. If this is not where you intended to be, you may stay with us and learn more about quality improvement projects and the City of Paterson's Clinical Quality Management Plan. All right, so we'll start off like we usually do, just to run through what today's meeting is going to be about. Can everybody hear me okay? Okay, I just got a message saying my audio may be poor. So if at any time you can't hear me for some odd reason, please let me know. So I'm going to turn off my camera while I'm presenting. So today's meeting, we're going to do welcome and introductions, reports and updates from the recipient's office, question and answer subrecipient technical assistance needs, excuse me, CQM committee training, updates on the CQM plan, care continuum dashboard, and preparing for our second PDSA for the grant year 2022. So it's going to be a lot of information today. Keep in mind, we're going to do some quick technical assistance on some processes like using Basecamp and where to find things. It can be overwhelming. So I just want to make sure everybody can get to past meetings and find the documents and how to use Basecamp, and we'll go through that fairly quickly. So we'll start out as we usually do to see who has joined us, and just a little bit of housekeeping here. So keep in mind that each subrecipient is responsible for identifying what we call a SPOC, or a single point of contact. What that means is when the recipient or the CQM consultant, which is collaborative research, reaches out to a subrecipient with regards to quality improvement or the CQM committee, these are the people who will be reaching out to, all right? So that means that they would be responsible for disseminating that information to any other CQM or quality improvement staff. So I apologize that we cannot list everybody who is on the project, but there will be an opportunity this time in the PDSA cycle and quality improvement cycle to list all of your staff. So we'll be able to make sure that you all get access to Basecamp. There'll also be a place for you to be able to share documents and disseminate documents and have conversations with other people in the CQM committee, right? So if you're standing in for somebody, I apologize that I cannot put your name up there every single time. So just wanted to give you all a heads up on that. I didn't want anybody to feel left out. We know that each of your time is very special and important to the committee. So we do greatly appreciate all of you who do participate in this. Again, we just have to keep it to one single point of contact. Again, anybody from your organization can join at any time. And if you would like them to become a regular member who receives information about this process, please let me know. And again, we can just add them to Basecamp and the email lists. All right, and so we'll start out with Bergen family. And I know Paula won't be here, but we have Graz with us today. Graz, if you want to introduce yourself, tell us what you do at Bergen family.
Hi, my name is Graz, Graziella, Graz for short. I work with early intervention services with Ryan White, and I help clients who fell out of care or who are newly diagnosed get linked into care.
Great, thank you. Buddies of New Jersey, is Abraham with us or someone in place of Abraham?
Carolina.
Good morning, Carolina. If you'd like to introduce yourself and tell us what you do at Buddies of New Jersey.
Yes, my name's Carolina, and I am the non-medical case manager supervisor.
Great, nice to meet you, and thank you for joining us.
Thank you.
So today you're responsible for taking all this information back to Abraham, but you can just point him in the direction of Basecamp, and he should be able to get to all the information, so you don't have to do too much. Yes, not too heavy of a lift. You're welcome. All right, Tisa Smith from CAPCO. And I know that you have some other colleagues with you as well.
Hi, my name is Tisa Smith. I'm from CAPCO. I'm a medical case manager here. Also, I do Hopwell.
Great. Thank you, Tisa, for joining us.
Hello, everyone. I'm Jerry Dillard, Executive Director at CAPCO.
Thank you, Jerry. And then you also have another colleague with you, sir?
It's yourself.
Hi, I'm Serenity, and I'm volunteering at CAPCO.
Awesome. Great. Thanks for joining us, Serenity. All right. Anybody else from CAPCO? All right. Miss Grace Jones from Passaic Alliance. Did I see Miss Grace? Maybe on mute. Thought I'd seen her come up.
Join the meeting.
Anyone else from Passaic Alliance? Let's see. All right, nobody there. All righty. Hackensack University and Medical Center, Miss Donna.
Hi, no, it's Mary Beth, social
Oh,
work.
Mary Beth. Oh, good morning, Miss Mary Beth.
I see you, Thomas. Good morning. Hello, everyone. So yeah, Donna's on vacation. So I'm infectious disease social worker, Mary Beth. So I'm here to attend.
Great. Thank you so much for joining us. And what is vacation? I'm
Yes, yes, finally.
No, that's right. All right. Thank you. Anybody else with you today, Miss Mary Beth? Okay.
No, it's just me.
Okay, great. Hyacinth. I think I saw Jokabed.
Hi, good morning, everybody. Jokabed from Hyacinth. I work as the client service manager.
Great. Thank you for joining us. Anybody else with Hyacinth? Jokabed?
No, just me.
All right, great. Miss Leah Ash, I know she's out today and she has a colleague joining us in her place. And I've lost the name. My apologies. Anybody from Northeast New Jersey Legal?
Yes, good morning, everyone. My name is Joseph Calacido. I'm the Director of Development with the program, and I'm just attending on behalf of Leah Ash today. So nice to be here.
Great. Thank you, Joseph. We appreciate you joining us. All right. Patterson Counseling, Alicia, are you with us today? Anybody else from Patterson Counseling?
Can you hear me?
Oh, there we are. Yes.
Yes, it's Alicia. I'm the Ryan White nurse and the case manager here at Patterson Counseling Center. And I believe Blanca is on as well.
Okay, great. I do see Blanca. All right. Thank you, Alicia. Blanca, would you like to introduce yourself? You are on mute. All right. Anybody from the Patterson Department of Health? All right. Mr. Roger Lester from Payne.
Good morning, Roger Lester, Executive Director, CEO of Preparing Adolescents in Adults Ideologies Now. Non-medical case management, substance abuse, health education, outreach. We do showers, we give out clothes, we give out food.
Awesome. Thank you, Roger. And so you have an associate.
Good morning, everyone. I'm Jerry Dillard. I'm the Chief Operating Officer at Payne. And
Great.
Roger, you have someone else that needs to introduce yourself. We see her in the background.
Hi, my name is Layla. I'm 7.
Awesome. Well, keep Roger straight today. Make sure he's taking good notes. All right. Awesome. Thank you for joining us, Layla. All right. St. Joseph's Hospital. Anna, I see that in the chat you're here. Thank you for joining us today. Anna's the patient navigator at St. Joseph's. And also Blanca put in the chat, she is the administrative assistant for the Ryan White program at Patterson Counseling Center. And unfortunately, she doesn't have a microphone, but she is with us. So thank you for joining us. Thank you both. Next, Priscilla Machella from St. Mary's. I know that she will not be with us today. I'm not sure if she's going to be able to send a staff member, but she is in the middle of kicking off Epic as their new electronic medical record. So today is their first day of, well, this is the first week of kicking that off. So it can be a little problemsome when you're running clinics and you can't get information in your EHR. So she's probably troubleshooting today. Anybody else from St. Mary's by chance? All right. Straight and narrow, Miss Gloria.
Good morning, everyone. I'm Gloria Price. I'm the clinical case manager here at Straight and Narrow Apartments. And
Thank you, Miss Gloria. And I think you have Miss Connie with you today.
Yes. Good morning, everyone. Substance abuse counselor intern here at Straight and Narrow.
Awesome. Thank you for joining us. And Team Management 2000. Was Ms. Jackie here or a representative from Team Management 2000? All right. Do we have any other members from the Ryan White Planning Council or guests who would like to introduce themselves at this time? I believe I saw Angelica Boatwright come in. Angelica, would you like to introduce yourself?
Yes, good morning. My name is Angelica Boatwright. I'm the Planning Council's vice chair.
Great. Thank you. All right. I see Destiny Johnson. Destiny, would you like to introduce yourself?
Hi, everyone. My name is Destiny. I'm the executive assistant for Buddies of New Jersey.
Awesome. Great. Thank you for joining us. Let's see. I think that might be everyone. And then our illustrious leader, Milagros, would you like to introduce yourself? Uh-oh. I don't think your mic's working again. I'm gonna have to fly up there just to fix your mic. Nope, we can't hear you. All right. Well, Millie is with us. So if we have anything for her, I'll help her with her, obviously with her recipient update, which comes up next. So just a quick update that we have received our notice of award. We made that announcement at the last CQM committee meeting. And that Millie is currently in the process of processing contracts and awards to subrecipients and getting that all squared away. Just a quick announcement. We've mentioned this a couple of times. So we will be conducting, and it looks like I spelled organizational wrong, but luckily I did not. We will be conducting an organizational assessment this year. The organizational assessment will give the recipient and the CQM consultant opportunity to meet with each of you to talk more in depth about quality improvement and your availability and ability to complete those projects. So we'll do kind of a little assessment to see, do you have the tools to complete quality improvement projects? And that will give us a couple, and we'll talk about a little more. That will give us some ideas of how we can help with technical assistance going forward. Today, we'll look at the CQM Clinical Quality Management Plan, its revisions and updates. So I have completely revised that. Millie and I have been going over that the last couple of months and revising that. We've made our edits and we will be presenting that to you today. And we will ask you to take the next month to kind of consider that and see, do these look doable? Does this look reasonable? Does this look measurable? That's the most important thing. Can we measure what we're trying to do? And making sure that we have all of our I's dotted and our T's crossed. I will tell you from the monitoring visit from HRSA, they absolutely loved our plan. So we've made some adjustments to it to make it even better, more easier to read and understand. And going forward, we'll make revisions to this like on the fly. So we'll make our big annual updates, but as things need to be changed as we go throughout the year, we'll do that as well, right? So that was one of the recommendations from HRSA. And then finally, due to the influx and resurgence of COVID-19, we will be remaining virtual into August as well. There's some new variants out, people are getting sick again, and we do not want to put people in harm's way. So August meeting, even though we were going to try to do everything at a hybrid methodology, August meeting will remain virtual as well. Any questions thus far? All right, so we'll roll right into, did I skip a slide? No, okay. We'll roll right in to training and technical assistance needs. So just to keep in mind that the recipient and the CQM consultant will begin distributing organizational assessments in the fall. And this assessment will focus primarily on subrecipients' ability to participate and conduct quality improvement projects. And so we're going to call the organizational assessment the OA, right? We need another acronym. So the OA will allow for the recipient to identify areas of deficiency and provide technical assistance. The OA will allow for the recipient to identify training opportunities, and the OA will allow for the recipient to provide TA for quality improvement projects. Next, I want to kind of talk about Basecamp. I think we're doing a good job of utilizing Basecamp, but I think we could use it just a little more. And as a refresher, kind of wanted to bring everybody back to base camp really quickly. And so I'm going to share my screen. I have a whole bunch of base camp projects. So please, when you log into your base camp, or for any reason, your organization has assigned you to attend or work on quality improvement projects, and you need access to base camp, please have your SPOC or single point of contact reach out to me, give me your name and email address, and I can get you into base camp. So when you log into Basecamp, you should see Bergen-Passaic CQM Clinical Quality Management Committee. All right, and so when you come here, you should have all of these tiles, right? You probably get tired of seeing all the messages that I send out, but this is where you can do that as well. You can send out messages, and there's a couple of different categories you can pick from. You can make an announcement, and you can choose who sees it. Like, do you want specific people to see it? You know, or do you just want to make a group announcement? You can do FYIs, you can do kind of like a pulse check, like, hey, I'm working on my quality improvement project. I'm stuck at doing the driver diagram. Anybody shoot me what theirs looks like as an example? You know, something like that. Like, this is an opportunity for you to converse back and forth without, you know, having to sit there, you know, like I do, and question things constantly. So it's an opportunity for you to be able to reach out to your colleagues to see what's happening. You can ask questions, or if you find an amazing training opportunity, please share that with your colleagues, right? Or an amazing resource in the community. And we can edit categories. We can add some categories if we feel like we're missing some. So please keep that in mind. And then, you know, if you want everybody to see it, and so for me, it allows me to post it to everybody. But if you just wanted to choose who you wanted to see it, you would just click in here, see the name, and let's say, you know what, I don't want Jerry to read that we're talking about him. So I'll unclick Jerry. It goes to everybody else. Jerry can still read it if he goes to the message, but it won't notify Jerry that we're talking about him, right? So you can unclick people or however you would like to do that. If you want to send a message specifically to someone while you're here, go up to what we call pings. It's like instant message, right? Click your pings and you can talk to people through here specifically. So if I wanted to talk to Derek, you know, and it will bring up your messages. So just click ping them. And this is all the messages that we've had in the past. And if you keep in mind, if you respond from your email, it's going to add your signature line every time, right? So I would recommend getting Basecamp on your Android or your Apple phone if you have that opportunity, because it will get rid of the signature line from your email. Otherwise, it posts it. No big deal if it does. All right. Next, I want to bring your attention to what we call docs and files. I've tried my best to kind of color code these by grant year. I didn't color this one. Let's color this one blue. All right, there we go. So these are some of the files that you can see. You can see all of the CQM committee meetings. So for instance, today, here's all the documents for today's meeting. You have the PowerPoint presentation, you have the worksheets we'll talk about, national monitoring standards, agenda, and the updated CQM plan. Let's say that you're like, hey, you know what, I remember talking about something back in December. You can go into the December meeting, and once today's meeting's over, we do record this. I will put the recording so you can watch the entire meeting into Basecamp, and you just click the MP4 and you can watch the entire meeting. So yeah, so keep in mind that things will be here. PDSA templates will be here. We'll create a new folder for quality management plans, and I'll drop in all the old quality management plans as well. And then as I start planning for the August meeting, you'll start seeing documents show up there. I don't typically notify people when documents go in there because you'll get a lot of notifications. So what I do there is just make them there for your availability. You can also create folders in here. So let's say that I'm working with Roger specifically, and I wanted to create a folder just for Roger and I to see. You can do that. You can create a new folder, and then you can basically say, you know, Roger has access to this folder so that you can share documents back and forth in that particular area. All right, the campfire is just kind of a place to chat. Like, you can throw out a question, like, I don't know. It's kind of like, remember you're getting the updates of, like, you know, how is everything going? Are there any training opportunities, etc. So you can just, this is a place to just casually ask the group. So if you don't want to do it in a message board, you can do it in the campfire, ask questions, share stuff, etc. The schedule will continuously be updated as the meetings come up. Again, like for today's meeting, you click here, you can click on add that event, and then you can actually add it to your calendar. So if for any reason you don't get it, the calendar invite, you can simply, again, in here, click on schedule, click on the meeting date, and add to my calendar. All right. And then finally, the automatic check-ins. This is what we ask on a monthly basis. Every other Wednesday at 9 o'clock, this message goes out. As things come up, we can start changing this. And what is your organization's training needs related to Ryan White service delivery, administration, and quality improvement? And so as you respond to that, we do take a note of all of those responses. And that's what we give over to the AETC. And that's how she develops a training mechanism and schedule for our TGA and CQM Committee. All right. And then finally, if for any reason you're like, you know what, I just saw that message from Mary Beth, but now I can't find the email where she sent it to me. If you scroll down, you can see project activity and what's happened throughout the entire day. So if you've lost that notice here where it says, hey, so if you're like me, I get tons of these because I have tons of base camps open. I lose them frequently. So I was like, you know what? I remember it was from Mary Beth. Just go down to project activity and you can track what's happened today and what's come into your folders, right? So you can look at it from day by day. So yesterday, this happened. On Thursday, July 7th, this happened. So it will give you kind of a rundown of what happened just in case you missed something. All right. Any questions about Basecamp? Yes, yes, ma'am. I'm guessing you need access to Basecamp. All right, any questions about Basecamp?
Thomas, did you see the question
I did not.
in the chat from Anna?
If you would like to attach something for everyone. So, okay, that's a great question. So you can. So Anna, so if you're in the message board, and the thing I love most about Basecamp is it's not an upload thing. You can drop and drag, right? So let's say I do a new message, and I'm just going to call it CQM Committee Test. And I'm going to pull over. So I have opened my, I'll pull it over here so you can see my CQM Committee file folder for my computer. And you know what? I'm going to drop in the agenda. You can just simply drop and drag. Done. You can type above it. You can type below it. Sorry, y'all. Put the caps off. Right, there it is. Now it's going to ask me, do I want to notify just, this is for collaborative research, the 3 members on my team, or FYI, or do I want to notify everybody? I'm going to notify all 32 members on this project. Post a message. So if you signed up for Basecamp and you have access to Basecamp, you just heard my email go off, you are going to get a notification that I just posted this, right? And if you want to respond to this message, you can set, there's a place here to add comments, right? And so as I go along, and let's say Mary Beth says, hey, you have a misspelling here, and I correct that document, I can go in and upload a new version of this document through the chat here, right? So I can say, here is the newest updated of the agenda, right? And then I could drag it over and repost it again. Also keep in mind, and Mary Beth, I see your hand, I've got you. Also keep in mind that when you add documents and files to these folders as well, the very cool thing is I can go with replace with a new version and it will track the versions. I love that because I'm infamous because of Word keeping the save all the time on of overwriting files and then freaking out an hour later that I overwrote a file. Now I don't have that file anymore. So this gives you an opportunity to go back and track and replace versions. And you can see that again, this will allow you to have a scrolling history at the bottom that says, here's an older version of that document, etc. I haven't replaced this one, but if it were replaced, it would be there. Does that help, Anna? I know it's a lot. Get in there and play around. I won't be mad if you send out a bunch of messages. Okay, Miss Mary Beth.
Thank you, Thomas. I'm so happy that you did a live interaction with us. I was very curious about how this all worked. So thank you.
You're welcome. I'm not going to lie to you. It took me a year. We started this on the SPINS project. I know Millie hates Basecamp because Boston University used to blow our emails up with the, because there's like 50 of us from different areas, and you get emails all day long of people posting comments. You're like, stop it. If for any reason at any time you're like, hey, you know what? Oops, let me go back in here. I don't want to hear, like, because you can comment to these, like, I don't want to hear about this anymore. You can unsubscribe from that particular post.
Okay. Okay.
It's not going to erase it out of the section. So if you want to go back and review it later and you're just tired of getting updates, you can unsubscribe. I will tell you that when I post, I force it to go through that everybody gets it. So I apologize. Not my comments, but at least like when I post new things, I force that it goes through. So,
I just have a question.
yes, ma'am.
I appreciate you sent me the PDF earlier. As I mentioned, the hospital blocks a lot of things.
Yes, ma'am.
Actually, they're blocking Basecamp. I can't.
Oh, no.
From the hospital experience. So I guess Don and I have to do it home or some other way. We can appeal it to see if this is like mandated through HRSA. I was just, wondering if you ever had this interaction with other facilities that they just can't access Basecamp, or can we just use that push that we really need this for the grant?
Right. I would highly recommend that maybe you ask the IT department to unblock Basecamp.
Okay.
There's no PHI here. Okay. So we keep in mind that we will never post any type of PHI. Okay. And if you do, I would delete it immediately because this is not a place to share content or things from consumers. Mm-hmm. But yes, ma'am, if you could possibly, also, if you have a smartphone, you can also get the app.
Okay.
I know that's not as efficient as you being able to drop and drag, but this is the best way I could come up with how we could convene everybody and make it a message board, and we didn't have to keep emailing. I feel like it was a, right. So if you need some assistance from me or the recipient's office in saying that this is a program that we're utilizing for our clinical quality management committee and that's required, mm-hmm. I'm pretty sure Millie will help you out with that.
Great. Thank you very much.
Yes, ma'am. You're welcome. You're welcome. All right. Any other questions about Basecamp? All right. So I hope that everybody starts to utilize this as we start planning for our next clinical quality management or a quality improvement project, because there's some new spreadsheets that I would like to use that will help us better track and better align with outcomes. All right. Do I have it still somewhere? No? Is this the right one? Sorry, I got to talk myself through this, y'all. All right. Well, next part is training. Oh, really quick. Basecamp, we did the quick refresher. Just keep in mind that it allows you to keep dates, places, to share your thoughts, and a place to upload documents and share documents as well. All right, the next training. This is going to be a very abbreviated training. I don't know how else to train people on national monitoring standards, but recently HRSA HAB in April did a training about their newly updated national monitoring standards. All right, and I know people who have been in the field for at least 20 years who are like, what are national monitoring standards? So if you're not used to doing the quality improvement, quality assurance portions of the grant application, these might be a little vague to you, right? So the national monitoring standards are developed by HRSA HAB to kind of outline the expectations for the Ryan White HIV/AIDS program. Okay, so we'll look at them very briefly. The purpose of the national monitoring standards is to consolidate requirements, set forth in relevant authorities, and outline suggested standards for how recipients and subrecipients can meet those requirements. As such, the national monitoring standards do not establish or impose legislative, regulatory, or programmatic requirements. Rather, they provide guidance on how recipients, lead agencies, and consortia can meet requirements and monitor those who have been issued subawards. So in other words, how to monitor subrecipients, right? So the national monitoring standards are broken down into 3 components. Those 3 components are program monitoring standards, fiscal monitoring standards, and universal monitoring standards. All right, so in the past, these standards have been built utilizing a table format. So they would have columns and you'd have to search the column and figure out, well, is that relevant to me, or is that relevant to the subrecipient, or is that relevant to the recipient? Is it both of us? Like, who does this? And so luckily HRSA has updated these to make it a little more clear. All right. So when we look at, and I think that was the universal monitoring portion. So part A is allowable uses of Ryan White Part A funds. So this will give you an idea of, again, this is the program monitoring standards. This will give you an idea of what can you do with Ryan White Part A funds. I would highly recommend everybody read this. Every time I read it, I have a new interpretation of the monitoring standards. I know Derek gets tired of me. I constantly say, hey, look on page so-and-so. I reread this. Now that I've read a different section and read that right behind it, I feel like this means something different. So please read this, familiarize yourself with it, and it will give you a really good basis of what can and cannot be done with Ryan White funding. The portion I like most is that now that you look at these sections, so here's a performance measure and the method for doing such. This is the recipient's responsibility, and then it outlines what the subrecipient's responsibilities are in a narrative form, which I absolutely love. In the past, again, it was in a table format. They were bulleted, and sometimes they were very hard to follow, right? Because it would go across 3 or 4 pages. And then if you wanted to look at the public health or the source citation, like, is it relevant to the public health service standards? Is it relevant to HRSA, HAB, policy clarification, or program letters, etc.? It will give you the source citation to find where exactly all of these guidances are recommended. So the program monitoring standards have some specific program monitoring standards for each of the service categories. So for instance, AIDS drug assistance program. This is the performance measure. This is the recipient's responsibility in administering the ADAP program. And this is the subrecipient's responsibility. Luckily, none of us here get any money for ADAP, so we can skip through that one. AIDS pharmaceutical assistance local. We don't receive that one. We will stop on one that we do get so we can kind of look over. So let's talk about early intervention services. I know this has sometimes been a point of contention here in the TGA, right? So what is early intervention services? So what HRSA says through the program monitoring standard is that Part A funds are used for HIV testing only where existing federal, state, or local are not adequate. So the only time you can use EIS funds to test is if you don't have any testing dollars in your area. We would still have to reach out to the program officer to get permission, etc. Document that individuals who test positive are referred and linked to healthcare and support services, and health education and literacy training are provided, enabling clients to navigate the HIV system. EIS is also provided at or in coordination with key documented points of entry, and EIS is coordinated with HIV prevention efforts and programs. So these are Millie's responsibilities for how to RFP, request for proposal, or RFA, request for, I can't remember what the A stands for. Anyways, how to do the contracting process, right? So what we're more interested in is what HRSA HAB says subrecipients should be doing under EIS. Subrecipients should be establishing memorandums of understanding, or MOUs, with key points of entry into care and facilitate access to care for those who test positive. For instance, what does this mean? So you reach out to testing sites. Maybe you have a local emergency department who's doing HIV testing. You make an MOU with that entry point to say, when you test someone positive, you immediately call one of our case managers or one of our EIS workers, and we come out, or we link that client immediately to support and medical services, right? Not all emergency departments feel it's their responsibility to link clients to medical care. Half of the time, emergency departments are for exactly what it says, emergencies, not ongoing care. So they're less likely to be worried about, is Thomas, who just tested positive, going to follow up with the HIV medical provider, right? They're going to say, hey, here's a list of numbers, here's a social worker number, call them, figure it out, have a good day. And then they're on their way. So that's why EIS is important, to look and locate those key points of entry into the HIV care system. Document provision of all 4 required EIS components in Part A funding. Document and report the number of HIV tests and positives, as well as where and when the funding for HIV testing occurs. We don't do this here. We don't use Ryan White Part A for testing. We do have organizations and subrecipients who are co-funded for Ryan White and another source to do testing, and that's kind of how they do their linkage. So Millie may ask you for your positive test results and the number of test positives. Document that HIV testing activities and methods meet the Centers for Disease Control. Again, if this was funded by Ryan White Part A, that would be a requirement. Document the number of referrals for healthcare and support services. So once you enroll somebody in EIS, you have to document those referral to healthcare and support services. Document referrals from key points of entry into the EIS programs, right? So EIS means that you're finding newly diagnosed positives, not holding a cookout in the backyard for friends to come by and you invite people to come to it. It has to be a referral for key documented support and core services. Document training and education sessions designed to help individuals navigate and understand the HIV system of care, right? So each jurisdiction has a very particular way that you have to navigate services to get into certain services, right? Got to get a case manager to get to medical transportation, to get food bank and get to medical nutritional therapy, right? You can't just show up at the doctor and be like, oh, hey, I'm HIV positive. I need a filling. Nope. You got to see a case manager so you can get the referral and get those things taken care of, right? Number one thing is documenting eligibility. Establish linkage agreements with testing sites where Part A is not funding testing, but it's funding referral and access. And obtain written approval from the recipient to provide EIS and points of entry not included in your original scope of work, right? So those are basically how to provide some of the EIS things. Now, on top of this, the Planning Council and the Recipient's Office develop what we call service standards. So on top of these particular program monitoring aspects, you'll also may have some local service standard performance measures that you have to comply with as well. All right, so does that make sense? That's kind of what the program monitoring standards are. The next one is health insurance premium cost sharing. And so it expels out all of those for the program monitoring. All right, close your eyes for a second. I don't want to make you dizzy. We're going to jump down to the next section, which is going to be, did I already pass it? Appliances. I have to go back up. My apologies. Let's go here to the table of contents. And now let's go to fiscal monitoring standards. So fiscal monitoring standards. The fiscal monitoring standards will outline the limitations of uses for Part A funding. So again, we'll go into more detail about what is an allowable cost and what's not an allowable cost, how to track and document program income, how to document and track imposition and assessment of client charges, how to manage the grant financially, property standards. So buying equipment, buying things over $5,000, buying things under $5,000, cost principles, how to track your administrative and programmatic funding, right? Remember, you have to keep that split 75-25. Administrative fees within a program cannot exceed 10% of the grant award. What your auditing requirements are. Do you need an A133 audit as being a nonprofit, or do you just need a single audit? Matching or cost sharing funding. Luckily, Ryan White does not require matching or cost sharing from subrecipients. Maintenance of effort, that's more Millie as well. Making sure that you have fiscal policies and procedures in place to correctly administer the grant under 45 CFR 75 and 2 CFR 200. So if you're a fiscal person, you know exactly what those things are. And then talking about unobligated balances. So let's really quickly look at unallowable costs. So the recipient shall provide the subrecipients of definitions of unallowable costs, and it's kind of outlined here. So you need to maintain a file with signed subrecipient agreements, assurances, and certifications that you don't pay for things that are not allowable in Ryan White, right? You're not out there buying houses. You're not out there buying cars. Those are things that are not allowable without, previous permission from the grant project officer. Ensure the budgets do not allow unallowable costs. Ensure the expenditures do not include unallowable costs. Provide budgets and financial expenses and maintain appropriate expense documentation. So, Millie asks for that on a regular basis about expenses and what you use the funds for, and she and her staff monitor that. All right, and then the final piece is what we call universal monitoring standards. And some of those include access to care, eligibility determination, payer of last resort, because remember, Ryan White is the payer of last resort, not most convenient, anti-kickback statutes, recipient accountability, reporting, and monitoring. So we'll really quickly look at determining eligibility. What's the subrecipient's responsibility in determining eligibility? Develop and maintain client records that contain documentation as required by the recipient of the client's eligibility determination, including the following. Completion of the eligibility determination is specified by the recipient. So this is the important part to kind of give you a heads up on. Even though HRSA has released policy clarification notice 2102 that outlines the new requirements for eligibility, if the recipient's office decides to go above and beyond that and still require everybody to recertify every 6 months, that's the requirement. So no matter what HRSA HAB says, we have to meet at least the minimum, and the minimum is what HRSA says. If the recipient's office exceeds that and makes it, every 6 months or continues to use the eligibility policy as it is stated, then that is what happens. Documentation of eligibility determination required in client records with documentation is required. One thing that I love to point out all the time is that when I come to do audits in multiple jurisdictions, your initial proof of positivity or proof of HIV diagnosis is not a undetectable viral load, right? Why is that? Because people who are not HIV positive have undetectable viral load. So that does not prove that you have HIV or that a client is HIV positive. You need a Western blot. You need very specific things that say that a person is positive. So again, an undetectable viral load under 200 or under 50, a PCR under 50 or under 20 is not proof of HIV viral load. Okay. Proof of low income, proof of residency, and proof of compliance with the jurisdiction's ADAP program. So these are these things that you can read through to look at. During the monitoring this year, we are going to be doing a very extensive review of program, universal, and fiscal monitoring standards. We have tested this pilot out in a couple of programs in your jurisdiction already. And it's a pretty heavy lift, right? It's a lot of documents that you have to have together, a lot of policies and procedures that you have to make sure that your organization has in place. So again, we do recognize that this is going to be something new and it's going to be something that we'll have to work on. It's not going to fix itself overnight. It might take us a couple of years, but it would just be on a corrective action plan. Any questions about the national monitoring standards? So those are in the Basecamp file. So if you are interested in viewing that in Basecamp, so if you go into Basecamp, you click files, go into today's meeting, the national monitoring standards are right here. All right, so download that. It's 170 some pages. It's great reading for the weekends while you're hanging out in the hammock or at the park. So familiarize yourself with those. Right. All right. All right, CQM plan updates. So I'm not going to read the whole thing to you. I'm going to just briefly skim through the document. Again, we are asking for each member to read through it. Keep in mind that Millie, the recipient's office, has the final approval of the plan. However, she would like for your input to say, yeah, you know what, this looks really good, or we might need to work on some things here. Now I have to find it. Okay, well, let's open it then. Committee, CQM plan 22. There it is. There it is. All right. So really quickly, there are some updates that we've made. So some new sections, and we'll go through those. Just an introduction of the TGA and our clinical quality management statement. It's a coordinated, comprehensive, and continuous effort to monitor and improve the quality of care provided to people with HIV throughout the TGA. So that's our big push, right? And infrastructure of the CQM program management, and quality improvement. So looking at the annual quality goals. So the annual quality management plan outlines how the CQM program will be implemented for the current calendar year. Our 4 main goals are to promote continuous quality improvement initiatives across the TGA, improve the quality of core medical and support services provided by the TGA, improve the performance measurement system to appropriately assess outcomes for people with HIV, And goal 4, ensure the comprehensive involvement of people with HIV in the quality improvement process, right? So we want to start making sure that we're inviting consumers once we get our second round of PDSAs and quality improvement projects done, the recipient's office is going to ask that each subrecipient bring one person who receives services from their organization to participate on the CQM committee. And that's going to be for us to get more consumer involvement on the committee as well. So when we look at the CQM infrastructure, so this year and last year, we had it in one of those little hierarchy diagrams that was a pretty picture. We had a lot more narrative about whose roles and responsibilities were whose and what. And this year, we took some recommendations from HRSA. It wasn't a corrective action. It was just some recommendations for improvement. And we've outlined who is the representative and the roles that they play and the responsibilities for each of those people. So the Ryan White Part A, Millie, is the Ryan White Program Director, Hoppel Program Director, and she's also a committee member of the CQM. Her responsibilities are attend the CQM meetings, chair and oversee the CQM Committee, lead the CQM Committee, endorse, champion and promote CQM program, provide leadership, approve the CQM plan, conduct organizational assessments, approve quality improvement projects and PDSAs, provide guidance, report CQM activities that HRSA have, and coordinate technical assistance and training for all of our subrecipients. Next, we have the CQM consultant, which is collaborative research, myself and Derek. Our responsibilities are very similar to Millie's in that we assist in a lot of the activities. So we attend all the meetings, coordinate and facilitate the CQM committee. We draft and update the annual plan, assist in the organizational assessment, assist in developing QI projects, assist in tracking outcomes, disseminate information and data. We coordinate the base camp activities. We provide leadership. We provide guidance. We assist in coordination of technical assistance and training. And we do all the CQM posts, agendas, meeting minutes to the website. Then we have RDE, and the point of contact for RDE is Robert. But I believe we have Jesse with us today. And Jesse is also he won't be with us every single time, but Jesse is also with RDE or eCompass. And they're the eCompass consultant, and they are also a committee member of the CQM committee. And they attend all the committee meetings. They provide statistical reports that consist of tracking clinical outcomes in eCompass. So they're our main go-to when we need a new report, we need a new tracking mechanism. They collaborate with the recipient and the consultant to track and extract performance measure data. They provide training to subrecipients on CQI, CQM, and eCompass activities. And we're going to start talking about being able to import certain data from individual EHRs or EMRs or health information systems into eCompass so that we can get better data for our viral load suppression and our continuum of care data and our continuum of care dashboards. Part A consumers are committee members. Their responsibilities will be to attend all CQM meetings, provide guidance to the annual plan, provide guidance to the TGA-wide quality improvement projects, participate in consumer satisfaction surveys, actively participate and collaborate as a consumer of services, disseminate CQM and QI activities to the community, and participate in mandatory CQM and QI trainings. Next, we'll look at our subrecipients. And again, this is the reason why we have the SPOCs is because we have to designate a very specific person at each organization who's responsible for leading the quality improvement activities at their organization. So we've listed all of the providers here. If for any reason you need to change your SPOC, just let us know. Just let Millie know. Millie will let me know. You can email us both at the same time and we can get those names changed and updated so we know who we're supposed to be emailing and messaging. All right, so for subrecipients, you are acting as a SPOC, a single point of contact, and you are also a committee member. Your responsibilities are to attend meetings, provide guidance to the annual CQM plan, participate in the annual organizational assessments, provide guidance to the TGA quality improvement projects, accountable for entering current and consistent service data for collection and reporting into the eCompass system, conduct consumer satisfaction surveys in alignment with the Ryan White Part A program, actively participate and collaborate as subject matter experts on the CQM committee. So like, you're the front line, you're the person who tells us what's working, what's not working, right? Involved in the day-to-day activities related to quality improvement projects, meet contract deliverables and participate in conducting PDSA cycles, develop and track quality improvement projects, disseminate CQM information to agency staff, participate in mandatory CQM and QI training, and present your PDSA findings and outcomes when appropriate to the CQM committee. Part B, we're still looking to identify a designee from the Part B, but their responsibility is similar to the Part C and the HOPL program, are going to be attend all committee meetings, collaborate with the Part A to align leverage and community-wide efforts, share resources, knowledge, and expertise by providing input to the CQM activities, and help with requesting state surveillance data, right? Right now, I've been working with Khalif, and we know Khalif's leaving in August, I believe, or is it July? It's soon, sooner than we need him to be. And so that's currently our point of contact for that type of data. Our Part C program, so here I definitely need to update this. It should not be state surveillance data. It should just be Part C data. So Part C, St. Joseph's, Anna, I believe you're the Part C rep, is that correct? St. Joseph's is a Part C. Can somebody tell me yeah or no? Maybe so. All right, so I think
Yes.
Okay, thank you. So St. Joseph's is the Part C, and that you're fine, Anna. And they'll be providing like Part C data for us to align it with. And then the HOPL recipient will give us outcomes from the HOPL program. All right, and what about our community stakeholders? So what are their roles and responsibilities in this entire process? So our biggest stakeholder is the Planning Council, right? And the Planning and Development Committee. And so their role and participation will be to review and utilize data from Planning Council activities, reports as part of the priority setting and resource allocation process, identifies areas for improvement, provides and periodically updates the service standards of the TGA, reviews and utilizes service data and reports, and use quality management data in decision-making. And so we'll look at data reports like service utilization, epidemiological profiles, cost utilization, performance measure outcomes, and quality assurance outcomes. P&D committee meets monthly, so we could possibly get feedback from them on a regular basis. And just a quick point of clarification, I do not intend that the CQM committee is going to continue to meet monthly after our second cycle. If everything's going well, we can drop that back to 2 months to see how that worked, and then eventually drop that back to quarterly to see how that works. Or if monthly is working for us, let's not fix anything if it's not broken, right? So we'll reassess that on a meet as needed basis. Research best practices and work done by other similar TGAs, conduct needs assessments, and act as the voice of the consumer in service delivery. Our AIDS Education Training Center, Ms. Michelle Thompson, they're going to provide education and training. So they do targeted multidisciplinary education and training programs for healthcare providers, including presentations on updated clinical guidelines, information, and new pharmaceutical chronic disease management, as well as they provide technical assistance and education to our CQM committee as well, and our sub-recipients. And then finally, community members, they provide community input. We'll ask that they attend meetings as well, participate in surveys and needs assessment, and again, disseminate the information they're learning from the CQM committee to community members so we can educate our community. So you may be asking, like, how are we going to evaluate all of the activities we're going to do? Well, we do that through what we call a quality improvement project, and that typically we say is PDSA, or Plan, Do, Study, Act. How are we going to disseminate and communicate all of this information? So our CQM plan will be disseminated through the CQM committee, our P&D committee on a yearly basis, Planning Council presentations on a yearly basis, the TGA's website and Basecamp. Service standards, again, that's how these areas will be disseminated. Frequency is how often and to who the stakeholders are responsible for making sure we do this. All right. Service specific outcome reports, annual site reviews, monthly service reports, and CQM bulletins. And again, the CQM bulletins are all of the postings we utilize in Basecamp. So the next big section is what we call performance measure. HRSA requires us to have a performance measure portfolio. If you remember from policy clarification notice 1502, this is the lovely chart they set up. Any Ryan White service that has more than 15% of the eligible clients utilizing the service need at least one performance measure, right? So greater than 15, but less than 50% of clients within the TGA using a service needs one trackable service measure. Greater than 50% needs two. So this is last year's data. We are still completing the portfolio, so we can update this. So this is the big update in this plan as well. The new service utilization data will be here. We'll look at the total number of eligible clients, the total number that were eligible for that service, the numerator, meaning how many people utilize that service out of this number, and it gives us a percentage. So we see last year that 37% of the clients utilized outreach services. That required us to have one tracking mechanism. Outpatient ambulatory, 1. Non-medical, 1. Medical case management, 1. And health education risk reduction, 1. So these will update on a yearly basis. Next, we talk about our care continuum, and this is going to be a new push for us this year, since that RDE has built out that new continuum of care dashboard that you're able to review in eCompass on whenever basis that you would like. So looking at last year's continuum of care, it doesn't look quite so good, right? So we are going to highly recommend that on our next PDSA cycle, that everybody creates a quality improvement project or a PDSA around making sure that there are viral loads in eCompass, right? So if that means that you have to start doing a data sharing program, or that you run your continuum of care dashboard and get those people who are missing indicators on a weekly, bi-weekly, monthly basis, then that's what's going to happen, right? Depending on how you set up your quality improvement project. So just giving you, this is a very low-hanging fruit that we can fix very quickly, and just by using data systems and data reports out of eCompass to address. So we had approximately 974 clients enrolled, 655 had one care marker, 266 had two care markers, 349 had evidence of antiretroviral therapy, and only 509 of those clients had some kind of viral suppression rate. My sneaky suspicion is that we're missing probably 25 to 30% of those even having documentation at all. So that's a very quick fix once you start running those reports. So again, the quality improvement process, we use the PDSA cycle. We've already talked about this in pretty great detail. And so the next portion is what we call our work plan. We've updated the work plan this year to include 6 sections. The 6 sections are goal, status, action steps, target date, who's responsible, and resolution notes. So right off the bat, we look at biannual review and update of the TGA's QM plan. We're going to look at that on July 13th, which is today, review. We're going to look at it again in March, and we're going to look at it again in August, see if we need any updates as we're going through our PDSA cycles. So our PDSA cycle will also kind of lend itself to ending a month before the update to the CQM plan is due. What are the action steps? The recipient and CQM consultant will present the CQM committee with the updated plan in July. They'll review the plan and give us updates or proposed changes by August. We'll finalize that proposed changes in August, and then the recipient will endorse and finalize the plan in September. Who's responsible? Here are the parties. All right. Next, subrecipient SPOC to submit quality improvement project worksheets, and we'll go through those in a second. So our next round of PDSA is starting. The QI worksheets will be due by the August meeting. So by August the 9th, I believe. Am I correct? August 9th. I can't see my calendar at this point. Derek, can you help me out on that? Is it August 9th, sir? The next meeting?
Yep, I'm pulling it up right now.
Oh, I know where it is. Hold on. It's at the end. Oh, the agenda. Ooh. Here it is. All right, there we go.
Yes.
Yep, August 9th from 11 to 12:30. It says hybrid, but it's because I created it earlier in the year. It will be virtual. So we'll ask you to have those completed and submitted, and then approved and kicking off the project in September. Next, we'll conduct reviews of those projects and approve those by September. SPOC to present. Okay, so here's the new catch. well, not catch. Here's the new way and why I'm suggesting that everybody do a quality improvement project on the viral suppression rates in your continuum of care dashboard. On a monthly basis, when we do our introductions, we are going, after the introductions, we are going to go right into the continuum of care dashboard presentations. So we're going to ask that each of you present your continuum of care. My apologies. So we're going to ask that each of you present your continuum of care dashboard. We're going to look at it very briefly today to see if there are any data elements or if there's any confusion on how that works. All right, so you'll present at September, October, November, December, January, and February. And then hopefully by that time, your PDSA cycle has worked very well, or you might need to make some adjustments to it and rerun that PDSA cycle. So that's that. Review outcomes of quality improvement PDSA cycles. So in March, we'll review those outcomes. And then the whole process starts all over again. In February, we'll start representing the quality improvement project worksheets. Again, in March, it will be approved, and then the cycle continues. Continuing with care dashboards, March, April, May, June, July. So this kind of gives us an outlook of how all of this is going to work going forward and what our goals are. Capacity building is still the same, like how we're using Basecamp and how we're using our AETCs for capacity building and trainings. And then finally, here we are to the quality improvement worksheet. So we attached that as an appendix this year. And here's the opportunity for us to list staff. Let me stop real fast, sorry. Any questions about the quality improvement plan so far? Initial thoughts, what does everybody think? Looks good. Seems a little more organized and aligned with our standards.
Everything looks good so far.
Okay, thank you, Angelica. All right, so our quality improvement worksheet, all right? So we're going to ask who the subrecipient is, what your project period is, and that'll be September to February. Who the primary is, so that's your SPOC, who your secondary is in case we can't get in contact with you. And if you want to list any additional staff, by all means, please do so. Give us their email address so we can include them. The title of your project, project start date, project end date, project location. So, you may have multiple organizations, maybe you have multiple departments. I don't know, big hospitals have multiple departments. Just depend, maybe you're just doing a case management. I don't, got to identify where that's going to happen. And then develop a problem statement. And so everything in blue with the blank spaces will need you to respond to with questions. And what I've done is I've tried to kind of give you some hints or helpful hints in the gray sections. What is a problem? A concise description of the issue being addressed, right? And things to consider while you're doing that. Create an aim statement. So what's an aim statement? I've given you some helpful hints of what aim statements are here. Here's a good example. Here's a bad example, right? By December of 2022, we will increase viral load suppression on the care continuum dashboard to 78%. A bad idea, we aim to reduce harm and improve patient safety for all of our internal and external customers. What's wrong with this? Right off the bat, there's no date, there's no goal, right? You got to set some numbers and some dates. And again, this might be February of 2023. The rationale, why do you want to do this? Next is, excuse me, is a driver diagram. And this is where it gets fun, I think, for doing quality improvement projects. So again, only pick one project, only pick one aim statement, only pick one thing that you're trying to solve, right? And I suggest, again, doing the viral load suppression. So what is our primary aim? So let's say our primary aim from up here is, by December of 2022, we'll increase viral load suppression, right? And how will we do that? So our primary drivers are increasing training and education on the E2 BP system. So making sure that our subrecipient staff understand how to enter that data correctly. And then there's some secondary drivers to that, require refresher training, require new staff training, and develop a training schedule. Change ideas, work with the AECT to provide mandatory training, work with RDE to provide mandatory training, schedule time for training. So at the individual agency level, make sure that you're giving staff time to train on that and document that staff training. So that's happening. So it kind of steps down to get to this part. Next primary driver would be to decrease the number of clients with missing data components. How can we do that? Run the continuum of care dashboard report. Maybe you're going to institute some compliance checks. Maybe you're going to institute some internal audit performance measures. And the change idea here is maybe supervisors identify missing data elements on a biweekly basis or a weekly basis. Data reports are provided to staff, document internal audit processes, increase communication with your clients, and incorporate daily E2 reports into their daily work to say, okay, I'm looking at my caseload and it looks like 5 of my clients are missing data. That's where you can increase your client communication and say, hey, Thomas, when's the last time you've been to your medical provider? And so it might not be a Ryan White medical provider. Okay, maybe we need to get a release of information sign so I can reach out to that provider to get your last lab. So being proactive in that. So again, increasing communication, knowing how to put things in. And then maybe another primary driver is increase the frequency of lab results for clients. So maybe your client's only going once every year, right? Either that's going to have to be something that you take as, I won't call it a hit, but recognizing that maybe you have a handful of clients that's going to bring your viral suppression rate down, or a list of clients who's going to bring your retention and care number down because they're only going once a year. So ensure clients are completing labs every 6 months. Encourage clients to use E2 My Health. Cannot stress that enough because then they'll also get reminders that they're missing data elements. Develop a client reminder system. Again, E2 My Health does that. Increase communication with clients and incorporate daily E2 reports. So kind of an idea of how to start developing out your driver diagram. If you get confused by that, simply Google driver diagram. There are millions of examples and help tools and aids there to kind of walk you through that. Next, we'll kind of do our plan, do, study, act. This is how we're actually going to do, again, the whole thing. So a lot of this is copied down, like what's your project title, what's your aim statement. Again, describe the objective of the PDSA cycle to give it specific focus. What is your change idea? Overview of your notes, describe your plan for carrying out the PDSA cycle. What is your prediction? And then start documenting some of the feedback, right? Describe what happens when you ran your test. Describe a compare for study, so PDSA, right? Study, compare the results. Act, describe the modifications to the plan, right? And then finally, data collection. So this will be a place for you to bring down your primary, secondary, or aim statements to say, what am I going to measure, right? So did I measure, sorry, going back up here, did I measure some of the ideas like reporting, documenting staff training? What are the things that you want to measure to see if it was successful? So here's an opportunity for you to measure those. What is your baseline when you started? Like, what is your baseline viral load suppression rate agency-wide? All right, and then you can measure it every month. And then what was the final outcome, right? Maybe you went from 33% to 93% just by doing a data element of running the report to see who's missing data and getting that data in. An example again, 63 to 71, right? So this looks like a very successful PDSA. You could rerun the PDSA in the next cycle, or let's say that it didn't go anywhere. What would you do? Maybe just doing the data report wasn't enough. Maybe you have to make it a change element. Doing it weekly wasn't enough. So now you're going to require staff to do it on a daily basis. All right. So looking at things like that. So just a simple tweak to the thing, to the PDSA cycle, and then you can move forward with that. All right. Any questions about the worksheets? I've tried to make them as self-explanatory as possible with lots of examples. So hopefully that will help everybody out in doing their next PDSA cycle. All right. So really quickly, let's look at how do I get this data out of eCompass? I know my view of eCompass is not going to look the same as yours, but we'll give it a shot, right? So when I log in, you're going to have a My Care continuum. I'm not quite sure where yours is located in your system, but you basically just want to hit My Care Continuum dashboard. When you do that, make sure you indicate, give it a second. You can you'll be able to do it by your agency and the funding source. So make sure you want to pick, I'm just going to do all, select all. And then I want to say, I want to do Ryan White and MAI funding, right? And make sure you get the contract year correct. So again, for me, I use last contract year. If you want to do it from a month-to-month basis, that's fine as well. So if, like, let's say you want to look at March of this year, all services, also all that good jazz. We want all that information. And then next month you'll run the April report to see where you are. And so for me, I'm going to see all the subrecipients. But what we want to do is look at this bottom number. So just for this, for the month of March, we had 403. So our viral suppression rate just for the month of March with data is at 75%. That's good, right? We wanted at 100, which means there's only about 100 people missing that data. You can click on there and see who those people are that are missing data, right? And so that's the easiest way for you to run that particular report. Again, this is our care continuum dashboard for 21-22 grant year. Viral suppression rate of 54% does not look good. It's fairly low. It's very low. Again, beginning on the August 9th meeting, we will ask that each of the SPOCs present their continuum of care dashboard at every meeting, just so that we can ensure that you are able to look at that, you're able to understand that information, and you're able to utilize that data going forward. Excuse me. Quality improvement project worksheets are due by August the 9th. There will be a folder on Basecamp for you to put those quality improvement project worksheets, to upload those, so you don't have to email them to Millie and I directly. If for any reason you have a problem with getting it into the Basecamp area, please just email it to us, no problem. Again, report of the outcomes of that PDSA cycle quality improvement project will be February of 2023. And then finally, as a reminder, it will be virtual. The next meeting will be August the 9th, virtually at 11 a.m. Eastern time. No, that was a lot of information, but I think we're there. I think we're in a very good spot with the quality management project and the quality improvement projects. And I'm very excited going forward. We are, the recipient and I and RDE are working very hard behind the scenes to develop some methods that we are able to track some of these indicators automatically going forward. So we're working on that. We're working on increasing efficiencies with the eCompass system. We're working on developing some training mechanisms and some training schedules and some mandatory trainings. So those will be coming forward very, very soon. Any questions about today? Any questions about anything we presented? Y'all are going to get some email blasts from me from Basecamp saying, hey, don't forget to review the review the CQM plan. Let us know if you have any suggestions, comments, questions. You're going to get the, hey, don't forget to do your quality improvement project worksheets. And don't forget to do your continuum of care dashboard right before the meeting. So I'll be sending those out. Some of those will be automated reminders. If you want to upload your CCD to the Basecamp post when it comes out, by all means do so. But please still keep a copy of it for yourself so that you can present it when we get to this committee. All right. Any questions? Any questions in the chat? Let me check chat again. Well, I thank you all for taking time and joining us today. I know not everybody gets excited about data, but we're trying to make it as exciting as it can possibly be. If we can make, like, I would be super excited if we could make that jump from 58% or 54% to like in the 70s or 80s by the end of the grant year. Like that would, I'm not rich. I would say I'll buy you all dinner, but I can't. We go to McDonald's. I can get everybody a cheeseburger and a fry. You order from the app, we can all get fries for free. But so, I'll try to do something special for us when we come back up there, when we start meeting in person again, hopefully soon. But I do appreciate all of your time and effort and trying to make this a very successful program. And if you have any questions, please don't hesitate to reach out to us. All right. Well, everybody have a great rest of your week and have a great weekend.
Bye,
And
y'all.
thank you.
See you, Jerry.
Be blessed.
Bye, Angelica.